What a thrill to be back here in Detroit. So thank Scott, thank Kim, thank you all for coming today. So this is, I haven't been to this meeting in like a couple of years. My daughter is an athlete at Boston University, and she's injured her knee not once but 2 years in a row, and each time it's been right in this period of this meeting, so I haven't been able to come. So this is exciting for me to be here. So one, thank you. As Scott said, I've been in this, been at the Brigham and Women's Hospital, it'll be 35 years in July. Oh my gosh, who spends 35 years, never mind 35 minutes in one location? But it's been a wonderful experience for me, and in the time period I've been there, worked in the pharmacy, but more importantly, in my playtime, right? So you carve out a few minutes of your day to interact with individuals, and I've had the wonderful opportunity during that time to work with our thrombosis research group, Dr. Goldhaber Piazza and others, Timmy Research Group and others. So it's been a great experience for me in the area of anticoagulation and thrombosis. So I thank you for including me. So the first thing you find out here is you can't see the actual slides, right? They're hidden behind yeah, all right, Kim, let's help. Here's our, yeah, exactly, here. So we're doing something for not us, but for the rest of the speakers of the day here. Look at this. Is that full service or what? Yeah, okay. Kim said, now we need some narcotics. We need some fentanyl. So anyway, there it is right there. All right, first thing of the day. So anyway, I got invited today, and here's my topic, to give you an update on anticoagulant therapy, but to talk about underuse, overuse, and special populations, okay? So is that the hodgepodge of activities? So I wanted to spend a few minutes to talk about anticoagulant dosing, okay? I wanted to give you some examples and what the challenge is, both in under-prescribing, over-prescribing, and then hopefully you take away some of the consequences of us really as clinicians not doing our job well. Okay, and then I'll focus on a special population. I want to talk a little bit about renal dysfunction before I finish the program. So I have about 45 minutes, which is great and never enough, but let's see if we can get it. And here's our outline. So let me start with talking about anticoagulant dosing. And it's actually where I left off the last time I came here 3 years ago in terms of giving a talk. Okay? So here's the opening question, and you can pull out your audience responses. So WC is diagnosed with acute proximal deep vein thrombosis. He's 7 feet 1 inch tall, and he weighs 330 pounds. When he walks in, he has to duck to get into the doorway, and he doesn't even fit on our exam table in our emergency department. So what's the correct initial dose of rivaroxaban for him? Is it 15 milligrams once a day? Is it 15 twice a day? Is it 20 once a day? Is it 20 twice a day? Or is this an incredibly stupid question, right? They used to tell me in pharmacy school there's no such thing as a stupid question, and I would raise my hand and they'd say, that's an incredibly stupid question. All right? So there's our first question, and you can log in your answers. Here's my second patient. WS is diagnosed with atrial fibrillation. He's at the other extreme. He's 4 feet 10 inches tall, and he only weighs 90 pounds, all right? And I put the body surface areas in, but they're totally irrelevant. So what's his initial dose of rivaroxaban? Is it 15 milligrams once a day, 15 milligrams twice a day? Is it 20 once a day? Is it 20 twice a day? Or is this just another bad question from the guy from Boston? Okay. Well, this is the reason I put these questions in, and it's where I left off 3 years ago, because we had embarked on a study. And what we found is 3 years ago, we had now a 2-year experience with a novel, direct-acting oral anticoagulants. And what we were finding is that about somewhere between 10 and 15% of patients, the doses were totally incorrect or inconsistent with what you would find in the package insert. Okay? And so we did this longitudinal study where we looked at these patients, and we found about half of them actually had reasons for why the dose was reduced. And you could go by the FDA labeling, and there are the different drugs that were prescribed by FDA labeling. But I urge you to look at the graphic and the dots at the top here on the right. these are the patients, and we thought most of the patients would have abnormal renal function, right? That the doses were being adjusted based on renal insufficiency or renal failure. And the answer was actually some of the patients qualified for the dose adjustment, but the vast majority of them, if you look at the cutoffs, were above 50 milliliters per minute in terms of creatinine clearance, and they actually had normal renal function. And we looked a little bit further in the Venn diagram at the bottom. There was some that had renal dysfunction and some that had what you could categorize as a drug-drug interaction. And some of the patients were frail and had a history of bleeding, but the vast majority of those patients actually had no problems at all. Okay? So here's our finding, and we published in American Journal of Medicine that, my gosh, as pharmacists, nurses, physicians, we should actually take a look at what we're prescribing because there's a fair number of patients that are inconsistent with the FDA labeling. We didn't have any outcomes data, but the outcomes data followed very quickly thereafter. And I put this in because WC is Wilt Chamberlain, WS is Willie Shoemaker, and if you look at them, they don't typically fall into what you would call a normal patient, right? And in the setting of fixed doses of novel or direct-acting oral anticoagulants, these patients represent a problem for us. So do we prescribe something less than what we would usually do for somebody like Willie Shoemaker? Do we prescribe something more for a massive human being like Wilt Chamberlain? And I pose that question to you because what has emerged now, and I will walk you through two different registry studies. The first is the Riete registry out of Europe and part in the United States that looks at patients with acute venous thromboembolism. And again, if you look at the graphic to the right, the top right, you'll see that they followed patients in their initial time period and then in this extension period after initial 3, 6, or 12-month treatment. And you'll find that many patients did have a reduced dose of a direct-acting oral anticoagulant during those time periods. Those patients were more likely to be elderly and have cancer or have renal insufficiency. But more importantly, what they found is that those patients that got a dose reduction, whether it was the dose itself or a reduction in the regimen, and you see in the graphic down the bottom, there was a 10-fold higher rate of venous thromboembolism recurrence in those patients that had an empiric dose adjustment than those that did not. So what's my message to you? And then finally, no changes in major bleeding, okay? So these are patients that are getting a dose adjustment downward, right? You're compromising efficacy, and you see no difference in terms of major bleeding, so no improvement in safety. And when they adjust for all comorbidities, these problems continue. So what's the message? The message here is you should follow the package insert. Do an empiric dose adjustment or dose reductions downward is not a good idea, whether it's Willie Shoemaker or Wilt Chamberlain. You will end up with a higher incidence of recurrent blood clots and no advantage in terms of a reduction in bleeding episodes. What about in the setting of atrial fibrillation? Well, just again, recently published in this last year, initially online and then in hard print, was information from the Orbit registry. And I like this study even more because not only did they look at dose reductions, they looked at patients that got a higher dose than what is normally indicated in the package insert. So the Wilt Chamberlain story, if you will. Again, dose reductions occurred in about 10% of patients. Overdoses occurred somewhere around 4% of patients. But the story is still the same. If you look at event rates, and they looked at all-cause death at the bottom. So we'll go to the top first in the pie chart. Again, we're looking at about somewhere between 10 and 15% of patients getting off-label dosing, either something reduced or something too much. And what happens in the event rates down the bottom? Well, all-cause mortality is statistically higher in those patients that are prescribed an overdose, if you will. The underdosing was pretty close to significant in terms of higher mortality rate as well. It was about a twofold difference, but it didn't meet statistical significance. In terms of underdosing, there was a higher rate of hospitalizations. And again, more major bleeding with overdosing, no differences in bleeding and underdosing. So what's my message here? The registry data is telling us the same thing in patients with atrial fibrillation. Follow the doses or the recommendations that are in the package insert that the FDA recommends. When you do this so-called empiric dosing, and trying to adjust on your own, what you will find is higher rates of adverse side effects and complications, okay? So that's my message, and that's where I finished at our last meeting. Now, what about the concept of under-prescribing, over-prescribing, and the therapeutic consequences? I assume that Scott is going to follow in the update section. There are a number of new trials that are emerging that look at both patients emerging out of the cath lab, patients with underlying coronary artery disease. But the concept here is that we are now not only using one anticoagulant, but we are adjusting the dose of that anticoagulant, and we are combining it with either aspirin or an antiplatelet agent in terms of efficacy. I point to the Pioneer and Redual PCI trials. There is a meta-analysis that just came out yesterday that again shows that using combinations of these drugs, novel anticoagulants, and typically in antiplatelet therapy, you can do better in terms of outcomes and reduce bleeding events. I'm not going to go into the details of this study, but just to tell you, when you look at these populations of patients, you are looking at those patients with either smoldering or stable underlying atherosclerotic disease. Why is that important? Because in the past, if we go back 10 years ago, this is work from Sonia Anand, who was a fellow at Brigham and Women's Hospital with us many years ago. She's now just a few miles north in Canada. Again, looking at the role of anticoagulant therapy in patients with stable coronary artery disease. When you look at a meta-analysis, again, you find a statistical reduction of about 20% in recurrent cardiovascular events by using these agents. What's the sequelae? The side effect profile, of course, is that you get a doubling in major bleeding episodes. But the drugs work. And if we can find the right dose and the right combination of these drugs, we should be successful. I'll point to Marie Gerhardt's recent publication on the management of symptomatic peripheral vascular disease. And if you look at the foundation of the goals of therapy and the reduction of cardiovascular risk and improving functional capacity, in the middle, the pillars of treatment still remain anticoagulant and antiplatelet therapy. Now, the problem with this is we're now combining these drugs. This is work by Alan Hirsch, one of our former vascular medicine physicians, and was at Mayo Clinic until his recent passing. My point to this slide is that we are now managing anticoagulant therapy, antiplatelet therapy in the face of multiple drugs and multiple comorbidities, and there is a price to pay, if you will, if you don't do this well. There is a price to pay if you look, because this cost of medications typically per year is astronomical at $4 billion, and this was several years ago. But the point here is we're managing lots of different drug therapies. If you follow the guidelines that have been recommended in the setting of atherosclerosis, again, we are typically using lots of different agents, but in the graphic to the left, you see that we only achieve guideline therapy in somewhere between 50 to 80% of patients. So there is a huge opportunity in terms of getting these drugs, anticoagulants and antiplatelet agents, on board. And if you can follow your guidelines, again, instituting guideline-driven therapy and the hazards ratio to the right, you'll see that we do much better in terms of reducing adverse cardiovascular effects and the individual endpoints by instituting guideline-driven therapy rather than not instituting guideline therapy. And again, another graphic for those that follow patients with vascular disease. Our consistent practices with guidelines needs to be improved, but if you can follow guidelines and you can get drug therapy on board, the outcomes for patients are much better. Now, why do I say this, or why do I bring this up today? Because I think we're in an era of being chastised for prescribing, okay? This is data from the Center for the Center for Disease Control in Atlanta. And if you look in the green graphic down the bottom, you'll find that 10% of our population is on 5 or more medications. If you look to the graphic on the right, you'll find that the vast majority of those patients are elderly. They're typically above 65 years of age, and about half of 65-year-olds are on 5 or more medications at any point in time. What's the suggestion? What's the implication? Well, the implication is we're overprescribing, is it not? That clearly we put patients on too many medications. Now with this crisis of opioid addiction and opioid overdoses, I think there's going to be enormous pressure to suggest that we don't need many medications or as many medications on board as we typically prescribe. But what I'll submit to you is that when we prescribe drugs correctly and for the indications that are needed, we do well. This is information that comes out of both the British community and in the United States in terms of elderly patients. But the surprising thing here, if you look, is if the conditions like atrial fibrillation, myocardial infarction, peripheral vascular disease, you'll find that in many elderly patients, these drugs are so underprescribed. And actually, we could do much better. And I've put this work, again, in the elderly populations in the United States. When you look longitudinally, real-world studies following patients, both at home and in nursing home settings, what you're going to find is that many, many patients are omitted or underdosed on medications that they need routinely. So I submit to you in our conference today that with a emphasis on things like avoiding drug prescribing, reducing opioids, that we somehow have to resist the pressures of not prescribing medications or under-prescribing in doses that patients typically need with anticoagulant therapy. Now, there is more information that would lead a clinician to suggest that maybe we should avoid drugs like antithrombotic therapy or anticoagulant therapy. This was a nice study by a sub-study of the ROCKET-AF trial looking at the use of rivaroxaban versus warfarin in atrial fibrillation. John Piscini out of Duke did this trial, and there were a couple of important messages. The first thing is lots of patients were on multiple medications of polypharmacy during his trial. And if you look at the hazards ratio to the right, what you'll find is for those patients that were on multiple medications, and you compared those that were on a lot, 5 to 10 or more, versus those that were only on 0 to 4 medications, the rates of major bleeding episodes were much higher on those patients that were taking multiple drugs or on polypharmacy, okay? The interesting thing is when I talked with John, he said that's not the message that we wanted to tell people, that there's a higher rate of major bleeding. The message is in the graphic to the left, that the rates of stroke and systemic embolism, whether you were on a small number of drugs, 0 to 4, 5 to 9, or 10 or more, there was no difference in the rates of stroke and systemic embolism in any of those groups of patients. I think the message was drowned out. The message is that you can maintain patients on a number of medications, and the efficacy side is still maintained. It's the safety side, I think, that we need to increase and add value in terms of vigilance. This is no different, so I know you have a lot of sponsors out back, so I am not slandering one company. But if you look, you'll see similar story with the drug apixaban and the Aristotle trial. Again, separating out patients that were on 5 or more medications. Again, a higher incidence of major bleeding episodes. But again, an important message here is that we need to manage these drugs effectively in terms of their therapy. Finally, I'll point this out because there was yet another nice article that came out, real-world study. This was emanated out of China. It looked at patients with atrial fibrillation that were on a direct-acting or novel anticoagulant. You can see them, apixaban, dabigatran, or rivaroxaban. But many of these patients were on concomitant medications that are contraindicated, okay? So still in a world where we have electronic health records and pharmacy systems that should pick up drug interactions, there was a fair number of patients that were given drugs that are contraindicated. They matched those patients to those that didn't receive contraindicated medications, and it should be no surprise. When you looked at individual medications, you'll find that there was some, not all, but some that were associated statistically with higher rates of major bleeding episodes. What's the message here? The message is that we are in a world of people looking at what we do in terms of prescribing. We need to get better in terms of the way we select our drugs, the way we dose our drugs, and the longitudinal care of patients in terms of the medications that they receive. Finally, I will tell you that I think we need to focus on our elderly population. This was a meta-analysis of anticoagulation therapy looking at different trials of the novel or direct-acting oral anticoagulants in patients who received warfarin in atrial fibrillation, and were comparing the results in just the elderly, the subpopulations of elderly versus warfarin. And the results in that study were maintained, okay? Meaning that the benefits of the novel anticoagulants in the elderly patients, they did better, okay, in terms of efficacy, and there were lower rates of major bleeding episodes, okay? That was the takeaway message. That's not what I look for in these trials, because I have no time. I sit and look at these trials, so I separated out and took what happens in the elderly patients that received dabigatran, and what is the comparison against the young population of the total population. And what you see is what you expect, right? The elderly patients have higher episodes of major bleeding episodes on all of the medications. So yet again, the message here is I think going forward, having these drugs available is one thing, managing them on a routine basis in terms of the patient populations we treat needs to get better in the way we do business. I wanted to touch base just a few seconds on medication adherence and non-adherence, because this too is an area where we need to improve. If you look, typically after a year's time, most of our patients, about half of them, stop taking their medications in the first 90 days. And in the first 6 months, you will find that about 1/3 of patients don't even get their prescriptions filled, so they walk out of your clinic without their drugs. And the persistence with anticoagulant therapy is important. It is important with antiplatelet therapy. And this is not a horse race. So this is something that patients will be on for the rest of, in most instances, the remainder of their life. And if you look over time, whether patients are new to anticoagulant therapy or have been on an anticoagulant therapy in the past, their persistence wanes as time goes on. The same is true if you follow patients with antiplatelet therapy in the setting of atherosclerotic disease. And so this is an area of improvement. From an outcome standpoint, if you look at patients, again, with underlying atherosclerosis, and you designate them as being either fully adherent in terms of their possession of their medications being greater than 80%, partially adherent or non-adherent, for those patients, again, in the hazards ratio graphic to the right, if patients continue to take their medications going forward, they're persistent, they're compliant with their regimens, there is a lower likelihood of adverse cardiovascular events in those patients that follow their medications. Is this a surprise? No, it is not, but it's the area where we provide the least amount of support for our patients leaving the hospital, okay? We have done a number of projects over the last year, Project Red, Project Boost, Pill CVD. We are trying to provide warm touches with patients. We're trying to provide them with education. We're trying to provide them with tools, reminders, cell phone applications, alerts on their pill bottles. We have not had a single home run ball that says any one of these strategies works incredibly well. Even the fact that we may call patients 72 hours after hospital discharge or encounter. So there is still a lot of opportunity in this field going forward to improve the way we manage patients, the way we manage their drugs over the long haul, over their lifetime. Okay? In the last few minutes, I wanted to switch gears and talk a little bit about anticoagulation and special populations. And I wanted to focus on renal dysfunction. And I wanted to separate it into two different studies that we published, or reviews that we published in the last year in the American Journal of Medicine. The first focus on patients with renal dysfunction and atrial fibrillation. You know, you should recognize that the vast majority of patients that come into your clinic with atrial fibrillation are going to have some sort of underlying renal dysfunction. Only about 40% of patients have pristine renal function and probably can go forward without any surveillance. The rest of the patients are typically going to have problems. And with that, you should recognize that there's an increased risk in these patients with renal dysfunction of systemic embolic events. So the rates are higher, okay? There's a higher rate or incidence of stroke. There are complications of proteinuria and other metabolites that are a result of the renal dysfunction that will cause problems concurrently in these patients, whether you like it or not. And then, as I suggested earlier, our national health and nutrition surveillance studies or examination surveys have typically shown that most patients have lots and lots of complications. So you are not treating atrial fibrillation with an anticoagulant in isolation or in a vacuum. There are other factors, including their comorbidities and co-medication therapies, that will cause problems for you. There's a vicious cycle here that patients with atrial fibrillation are more likely to progress on to end-stage renal disease. There's a higher mortality rate. There is a reduction in survival in these patients as renal function, so survival decreases as renal function decreases. And we don't know the real reasons for this, okay? There is lots of speculation in the literature. If you go through the manuscripts and the publications, you know, surrounding things like endothelial function, platelet function, coagulation factors being manipulated, inflammation, etc. But we don't know the real reason. But what we do know is the patients, as this progresses, they become more complicated to treat. Okay? Oral anticoagulants for non-valvular atrial fibrillation, again, fall into the categories of warfarin and direct-acting oral anticoagulants. Typically in the past, I think most people would tell you there's no dose adjustment or there's no work changes for warfarin. We keep doing what we normally do, which is we give doses of warfarin and we test our INR and we make manipulations and schedule or dosing. And we don't know, what we do know though is that for patients that are on warfarin, that there is typically a need for less warfarin or reduction in doses, and those patients are typically have less stable INRs over the long term. Now, why is that? Again, there's lots of speculation in the literature, whether it's related to changes in blood flow to the liver or regulations of the cytochrome P450 system, but we truly don't know the answers. And there is conflicting data, too. If you go back to data from Mike Lazarus and Ray Akeem, there is data that suggests there is limited value to prescribing warfarin in these patients with atrial fibrillation. On the other side of the coin, we've had the novel or direct-acting oral anticoagulants for a number of years now. We know that they're all renally eliminated, but typically those patients with renal dysfunction were excluded from many of the clinical trials, certainly on the VTE side. We'll talk a little bit about atrial fibrillation in a second. And the estimates for renal function were based on the Cockcroft-Gault equation. So an important message here is there's still a lot of learning that needs to happen in the setting of renal dysfunction. I'll point to the fact that there are a number of different equations to estimate renal function in the literature, and what you probably have embedded in your electronic health record. It's important for you to know what equation is being used. because there were different cutoffs in the clinical trials, and I'll show you that in a second. Dabigatran was slightly different than edoxaban and rivaroxaban, and apixaban in the setting of atrial fibrillation used a serum creatinine value of 2.5 milligrams, or a calculated value of less than 25 mils per minute in terms of their dose adjustments. All right? So the equation is important because if you use different equations to calculate renal function and you follow the package insert dosing, you will find that you will end up with different dosing recommendations depending on which equation you used in terms of your calculation. So anywhere from 25 to 30% of patients using something different. So the clinical trials used an estimated creatinine clearance using Cockcroft-Gault and an actual body weight in their equation. If you use an equation other than the Cockcroft-Gault, you may end up with a different dose recommendation based on the package insert, and that's important to remember. So in our publication that we did in American Journal of Medicine, we put some graphics in. I happen to like this one, so this is intended to depict renal function or creatinine clearance on the left hand of the bar graph, and the doses of the novel anticoagulants on the right-hand side. And what I think is important to measure or recognize here is that at different levels, the trials were different, again, in terms of their cutoff and what doses reductions were recommended in those trials. We went ahead and, again, took the different trials that were out there and pooled them. I know you are not supposed to do cross comparisons of trials. That was not our intent. Our intent was to simply put the trials side by side and look at them in terms of outcomes. We recognized that there were differences in the patient enrollment and CHA2DS2-VASc scores, and that the patient populations were different. The definitions of atrial fibrillation and atrial flutter differed across the populations. But the point was is we were simply trying to compare the drugs, okay, and the results of the trials across the portfolio, if you will, or the landscape of trials that we had available, okay? So we were looking at the RELY trial, the ROCKET-AF trial, Aristotle, and ENGAGE-AF. And these are the results that we found. So we generated a manuscript. What happened in the subpopulations of varying renal dysfunction in terms of stroke and systemic embolism? These are the results, and I've highlighted the differences that were statistically significant with a red box. And let's go through each level of creatinine or renal function one at a time because I think they're important. So in terms of stroke and systemic embolism, all right, if you lose the cutoff, patients essentially having a creatinine clearance of greater than 80 mils per minute, what you would describe as essentially mild to normal renal function, these are the rates of stroke and systemic embolism per 100 patient years depicted on the bottom. The black is warfarin, the gray was the novel anticoagulant. The numbers down the bottom on the x-axis are reflective of the number of stroke and systemic embolic events that occurred with each population of patients in the drugs. So what's important here? Well, in the individual trials, in these patients with essentially normal renal function, there was no difference in the rates of stroke and systemic embolism, no statistical differences between the groups. Do you notice anything amongst the gray and black bars? I would tell you no, not at this point. But if you look at the bottom, numerically, the novel anticoagulants won in terms of a lower number of stroke and systemic embolic events. Okay? Let's go up higher. Okay, what about the patients that had clearly normal renal function? Well, there was a trend, and this is where the edoxaban drug got into problems with the FDA. There was a trend where there was a lower efficacy relative to warfarin in terms of stroke and systemic embolism. A trend, not statistically significant, but numerically there were higher numbers of stroke and systemic embolism with edoxaban than warfarin. Was this the only drug that had this happen? No. If you look at the Rocket AF trial, you find that the same thing happened with rivaroxaban. Numerically, there was a higher rate of events in those patients that had creatinine clearance greater than 95 mils per minute. Why do I put that out there? To recognize that there's differences in the labeling that you may have been, because edoxaban was late to the party, their labeling becomes a little bit different. But is it unique to their drug? My answer is typically no. Okay, let's turn to the other side and start going in the other direction where things start to plummet, okay? So these are patients with what would be described as mild to moderate renal impairment. I've highlighted in the red arrows the drugs that were, or the events that were statistically significant, meaning the novel anticoagulant in patients with mild to renal impairment did better than using warfarin at a target INR of 2 to 3. Okay? And you can see the numbers down the bottom. What's important, again, I think, is that if you look numerically, the novel anticoagulants win again. Okay? So there are fewer events. Not statistically significant with rivaroxaban, apixaban, but maybe that's reflective of the overall patient enrollment and the types of patients that were enrolled in the trial. But the message, what I'm getting at here is you're starting to see the differences of the novel agents being better. What happens if we go below 50 mils per minute? Again, only one of the drugs shows up to be clinically significant, that is dabigatran, in patients with moderate renal impairment. The other drugs are non-statistically significant, but again, if you look at the numbers, the drugs, the novel agents, do better than what we've seen with warfarin. If I go back for moderate renal impairment, if you look, again, this concept of trends seeing that the warfarin does worse in terms of the efficacy side. What happens if we move to the safety side and look at major bleeding? So again, when we differentiate the different levels of renal function in this graphic and the different drugs that are available, and we highlight the drugs that show a statistical benefit in terms of efficacy, you'll see them here, and we'll go through them briefly. Again, with the different categories, if we look at patients that have a creatinine clearance of greater than 80 mils per minute, the bleeding rates for dabigatran, apixaban, and edoxaban was similar, but again, slightly numerically lower than what you saw with warfarin. If you look at rivaroxaban, you'll see that the rates numerically the rates were slightly higher, but no statistical difference in terms of the outcomes of any of the agents. So in patients with what I would describe as mild to normal renal function, these drugs perform pretty much the same. What about if we change the range from 50 to 80 mils per minute? So only one drug now appears to be statistically significant. It's apixaban, recognized from your pharmacodynamics that is the drug with the least amount of renal clearance, so it shouldn't come as a surprise. But again, if you look at the gray bars versus the black bars, you see this trend emerging that the novel agents do better. And then finally, if we drop to a classification of creatinine clearance 50 milliliters per minute or less in patients with moderate renal dysfunction, again, the only agent that becomes statistically significant is apixaban in this category. The other drugs appear to be about the same. And again, slight differences, if you will, in terms of rivaroxaban having the same number of numeric events, dabigatran actually having more events. But statistically, the drug's performing as well as what you saw with warfarin. Okay? Now, what happens if we get into even more severe renal dysfunction? Okay, so these are the patients that were excluded from the trials in atrial fibrillation. Well, we don't have a lot of data. The first trial that I show you is from Japan. It was a small trial looking at dose-reducing doxaban to 15 milligrams once a day in patients with a creatinine clearance of 15 to 30 mils per minute. They compared the pharmacodynamic parameters to doses of 30 or 60 milligrams. And in terms of a comparator, the 15 milligram dose in these patients with renal dysfunction more followed what you would see with a 60 milligram dose in patients with normal or mild renal impairment. So if you were going to use a dose, the 15 milligram once a day dose appears to be the place to go. What about apixaban? Well, again, a small study with 32 patients compared to the 10 patients with normal function, the patients with renal dysfunction in different categories. Again, the apixaban exposure by pharmacodynamic definitions, as renal dysfunction increases, the rates or the exposure increases dramatically. Now, does this tell us what to do with the dosing? No, I don't think it does. But if you look in the package insert, you will see recommendations for both apixaban and rivaroxaban in the setting of hemodialysis. And these recommendations were based on small trials, okay, 8 to 10 patients. Typically, you are taking a patient, giving them a dose of the novel agent, and then taking them to dialysis, and then measuring pharmacodynamic parameters, letting it wash out, taking them to dialysis again, and giving the dose of the novel agent after dialysis and looking at pharmacodynamic parameters. So there's not a lot of information here, and they're typically trying to mimic or look at those pharmacodynamics versus a normal population of patients. And so your recommendations from the FDA, you should recognize, is based on really, really tiny numbers of patients, not on efficacy data, and certainly not on safety data. Okay? And so I'd urge you to recognize that most of these studies have been performed without looking at repeat dosing and without looking at the possibilities of drug accumulation. All right? There is some emerging evidence that has come out in the last few years, and certainly in the last year, looking at repeated dosing of apixaban at 2.5 and 5 milligrams twice a day. Again, when you look at exposure of these dosing regimens, the pharmacodynamics suggest that your exposure is somewhere between 2 and 5-fold higher with these, even with these doses. And so that package insert dosing that recommends 5 milligrams twice a day in dialysis, I'd suggest to you may not be the exact dose that we want to carry forward. There is a clinical trial that's ongoing. The Renal AF trial, Chris Grange's group and Duke is looking at different doses of apixaban in patients that have both renal dysfunction and hemodialysis. And I think in the next year or so, we should see information that emerges that tells us what we should be doing, at least with one drug in this population of patients. So I think the message here is we have a long way to go. Finally, and I'll cover this with one additional slide. I'll talk a little bit about renal function preservation in a second. But the concept of patients having worsening renal function over short periods of time. But we didn't have a large population of patients to look at here, so recognize that only 1 in 10, maybe somewhere between 10 and 25% of the patients that renal dysfunction is plummeting, and we're trying to adjust these doses. And so again, there's not a lot of information in this patient population other than to say that there appears to be similar results in terms of providing novel anticoagulants in comparison with warfarin in this patient population. So worsening renal function over time is yet another area where we need to improve or collect some more information. So the conclusions of our study, if you go to the American Journal of Medicine, was that, again, as patients get older, renal impairment will clearly increase. There is an increased risk for thromboembolic complications and an increased risk of bleeding complications. If you're going to do dosing with a novel anticoagulant, you need to follow the Cockcroft-Gault equation using actual body weight to get the right doses. In mild to moderate renal impairment, the DOACs are associated with a reduction in stroke and systemic embolism and a reduction in major bleeding. When you look at these agents, you pool them, whether it's numerically or statistically. In those patients with severe renal dysfunction, and in those patients with hemodialysis, and in those patients that have fluctuating renal function, I would suggest to you, and our authors suggested, that the DOACs may not be the drugs that you want to use. But they certainly confer a better renal risk benefit than warfarin in these patients, and there may be additional things that we need to do in terms of assessment, in terms of surveillance, to make sure that these patients are adequately followed and dosed going forward. All right? Let me switch gears to 1 minute because I thought this was an important trial. Clearly, the direct-acting oral anticoagulants have added a huge benefit to us in terms of drug therapy going forward, a huge advantage over warfarin. But an interesting study that came out, again, out of Mayo Clinic, published in JACC just at the end of last year, and I actually had a chance, I was one of the reviewers for this article, and I thought it was fascinating. And it took like 6 months to review because it was extremely complicated, and there was thousands of pages of results and graphics. But if you read this article, the interesting point is over time, when you look at patients that received a direct-acting oral anticoagulant versus a novel versus warfarin, that the endpoints of renal dysfunction seem to be preserved in the patients that receive the novel agents versus warfarin. So if you looked at things like a reduction in eGFR, or rises in serum creatinine, or acute kidney injury, there was clearly a benefit over the long term with a novel agent versus warfarin. And if you look at the graphic down the bottom and you look at progressive renal dysfunction, that clearly warfarin was the worst agent, and that the novel agents performed better. And there were differences in terms of the endpoints. Some of the novel agents were better than others. But when you point to an advantage of the novel agents, one of the things that you may want to consider is that in elderly patients who are having changes in renal function over time, that if you can preserve that renal function by giving a novel agent over warfarin, then that's a huge benefit. Now, there's all kinds of speculation if you go to this article about the reasons why warfarin may be a cause of progressive renal dysfunction. Maybe it's calcification. Maybe it's related to its anti-inflammatory actions. The answer is I don't think we'll ever know. But the fact that there is a benefit in terms of novel agents is helpful. In my last couple of minutes, I wanted to talk about venous thromboembolism. So we did the same thing that we did with atrial fibrillation. That is we took all of the major trials that used a novel agent in the setting of acute venous thromboembolism. The background is still the same. So if you look at patients who present to your hospital with acute VTE, you'll find that about half of them have renal dysfunction when they walk in the door. So they are not the pristine population that you typically saw in the clinical trials. And if you look, you'll see that there are clearly more events in terms of bleeding episodes, more complications in terms of recurrent venous thromboembolism, whether you look at the Light trial in Canada with Russell Hull or Fred Anderson's trial in the Worcester area, the complications are higher in these patients that have renal dysfunction. The registries have shown this out. The Riete registry, again, Fred Anderson's registry in the Worcester area of Massachusetts, all of these patients will have higher rates of complications, including bleeding as well. What's important in the trials, and you probably can't read this from the back of the room, but it's in your handout, that these patients with renal dysfunction were typically excluded from the clinical trials, both Recover, Einstein, Amplify, and Hokusai. But yet when you look, there were numbers of patients that once enrolled had deterioration in renal function. The important message I had, and I'll do this in a couple of slides, is whether you look at patients with normal renal function, whether you look at those with mild renal impairment or those with moderate renal impairment, there was no statistical difference when you compared the novel agents versus warfarin. Okay, so in terms of the benefits of reductions in recurrent events, just like the pooled analysis played out, no benefit in terms of using a novel agent over warfarin. What about the bleeding episodes? Similarly, okay, when you look at patients with normal renal function, mild or moderate renal dysfunction, again, no statistical benefit. Okay, so the benefit that showed up in the meta-analyses of the novel agents disappears in the setting of renal dysfunction. But what I'd urge you to look at is, again, numerically, the black bars of warfarin typically are higher in patients with mild to moderate renal dysfunction than they are with a novel agent. So there is a trend here again suggesting that in renal dysfunction, in the setting of acute venous thromboembolism, that these agents may be a little bit better. You can read my results again from our trial. I think the message here is statistically no difference in recurrent events, statistically no difference in bleeding events. There is an edge in terms of trends, and that's something that we probably want to look forward to. So again, in terms of conclusions, renal impairment is common. I think we need more studies going forward, and I would encourage you to follow the inclusion-exclusion criteria that was developed in the clinical trials surrounding venous thromboembolism and DOAC. So let me finish, and I'm already 1 minute over. My first message is follow the package insert dosing, okay? So whether a patient is big or small, follow the package insert dosing. You are consistent in terms of your practice, and your results should be consistent. In terms of under-prescribing and over-prescribing, there is tremendous emphasis now to not prescribe medications. I would urge you to ignore that, and in the setting of the trials, I think you'll hear about later, we are going to be using these drugs, and we are going to be using them in different doses, and we are going to be using them in different combinations, and we need to be good at it. Okay? Finally, the patients with renal dysfunction represent a challenge. I think from the AF side, it's pretty clear that from a stroke and systemic embolism standpoint, from a safety standpoint, the NOACs do better. Is there one that appears to be better than the other? My answer is no. We don't have enough information on that. And in the setting of venous thromboembolism, it's a wash. The NOACs are as good as warfarin. Nothing appears to be emanating from a statistically significant difference in terms of renal dysfunction. But yet again, there are trends that may show some benefit. And with that, I'll finish. Thank you for including me today. I hope we have a great symposium.
Hi, I just had a quick question.
Sure.
You were nice enough to share your thoughts on several patient populations. Over the course of the last year, a handful of times, I've had patients who have had either gastric sleeve or gastric bypass surgery, thereby interrupting their ability to uptake the NOACs, things like that. I typically tell prescribers when they put patients on one of these, it's not generally recommended. I was wondering what your thoughts are on that. I mean, I know we can stick a patient, get an INR, make an adjustment, and I know that we can't do that with the NOACs. So I didn't know if there had been an update that I'd missed or if there was anything you could share with us on that topic.
I don't. I would tell you we are following the same principles of management of these patients, and we're still down to really, I think, the discussion surrounding bioavailability, where warfarin is 98, 99% bioavailable and pretty consistent, and we have a lab test. And with the other agents, you've got the challenge clearly for drugs like dabigatran, where the absorption is minimal. There's a problem. It becomes a problem if we have to turn these agents into, for that drug, we can turn them into slurries. But I think I would follow the same, we're following the same strategies that you are, defaulting to warfarin as our standard, and if necessary, we will use one of the novel agents. Typically, the choice is if any of them, usually apixaban has been our choice, and I don't think there's a rhyme or reason for that in terms of our selection, other than twice a day may be more forgiving than once a day.
Okay. I had one other question for you.
I don't know if any of the other experts here will default. I see a whole row of experts in the front that are, if you ask my wife, I'm no expert, but other questions?
Just one other question, I'm sorry. You were talking about the eroding renal function and how warfarin apparently is the worst for that scenario. I'm just wondering with that study, is it possible when they were assigning patients to groups, if there were risk factors for them having eroding renal function, they could have been assigned to another group versus the warfarin group? There was just the one slide on it. I didn't know if there's anything you could share with us on that.
Yeah, I wish I had more to tell you on that setting of patients that are having rapidly changing renal function and then being able to follow them with long-term therapy. And I don't have an answer for you. I think this is yet another population that could be in the setting of critical care practice, maybe in the setting of home therapy, that you still need to monitor, I think, closely because of the changes. I don't have an answer for you other than the fact that I think this is an area where we need to collect more information and standardize certainly the populations that we're treating and the definitions of changes in their status.
Umberto Campia from Brigham and Women's.
I've met you before.
How about patients with cancer? Now we have the results with the doxaban. Are you considering using also other NOACs in that context?
Umberto, I sit on the National Comprehensive Cancer Network panel that draft guidelines for cancer patients, and we continue to have this grand debate. You've got the Efficacy trial now that has come out and showed benefit in terms of the drug being efficacious, if you will, but with a higher complication rate in terms of major bleeding. So do we have that drug to use in everybody with cancer? I still think the answer is no, and on our panel we still default as our standard being low molecular weight heparin going forward. There are a number of trials that are ongoing now looking at rivaroxaban, apixaban. There are a number of trials going on in subpopulations of cancer that I think will give us more information about how to move forward. I think the recommendations now, I know many of the patients won't tolerate long-term low molecular weight heparin injections if you've ever done them, that many patients can't afford the novel anticoagulants, and so despite what the guidelines recommend, there are still many patients that are receiving warfarin, and there are still many patients that are getting novel anticoagulant therapy. I think we just need to collect that information. There's some real-world information as well. I think systematically we need to do it in a clinical trial and have better results.
Thank you, John. That was great. So as Dr. Cates mentioned, I'd like to this time around to just kind of take a different spin on how we're introducing our speakers, and I think you could read everything about them and their credentials, but I'm always intrigued when I meet people or I see people, maybe you might be reading an article about them, is to wonder where they came from and how they got to that point where they were. And when I asked our next speaker, tell me a little bit about how you got to where you are now, it was very inspirational to hear her story, and I wanted to take that and spin that through the day as we introduce speakers. So how many of you, just by a show of hands, has anyone, when you were going through your education or your career, ever told you you couldn't do something? Show of hands. I know it's more of us. Don't be shy. Okay. And maybe when we were younger didn't have maybe the confidence. Did all of you know that you wanted to go into your profession, say when you were 15 years old? How many of you in the audience know exactly what you're doing today is what you wanted to do at age 15? Okay. So look at who's raising their hand here. Raise your hand again. Our next speaker. Okay, so I was intrigued at her story, and when I asked her, so how did you get to where you are today? I was very interested, and I asked her this morning, I said, you sure I can share your story because I think it's a good one. So at a young age, she knew she wanted to be a physician, and she believed in that, and she had the drive, and I think to be in healthcare, we would all agree that you need that passion and drive. And she said, well, one of my, I believe it was an instructor, said, you're not going to be a physician. You're not cut out for this. Convinced her this at a very young age through her passion, through her drive that, you know what, this is not for you. No, you're not going to make it. So I just listened. I said, so what did you do then? And she said, well, I became a teacher. And I said, well, that's great. Teacher is a very honorable profession. She said, but that's not really what I wanted to do. But at the time, she said, you know, I used that profession that time to gain some confidence and believe in myself. So then she said, you know, after that, she talked it over with her husband and said, you know, I'm going to take my prerequisites and I'm going to do what I wanted to do at 15, in an age of where I really have my passion lies. So she took her prerequisites and she applied to medical school. And how many of you in this audience know where she went to medical school? Harvard Medical School. So to me, I wish I had my two kids next to me to say, you don't let go of your passion. You never let anyone tell you you can't. You always believe in yourself. And I think that it was very nice to hear her story because this is where she is today. She's with us. So fortunately, she has been able to not only go through Harvard Medical School, but now she's working at Mass General. How many of you heard of Mass General? Okay. 2 hands up, okay? Top 5 hospitals in the country, year after year. And great work being done there. So our next speaker, we're very fortunate to have here today and thank her for taking time out of her busy schedule, Dr. Rozovsky. I had a pleasure of having a wonderful conversation hearing about her life yesterday. A wonderful person. She is now the Director of Thrombosis Research at Mass General, and she'll be our next speaker. Please join me in welcoming her today.
Thank you. Ooh, I'm a little short, so I might come out into the front.